So Michele gave me his slides last night. So the title was Role of Second Autologous Stem Cell Transplant. So I was thinking he's going to talk about salvage transplant, and he did not. His slides are about tandem auto. So the first part of the talk will be about tandem auto, and then I made slides on second auto at relapse. So I just need to, okay. So this one, to remember you that the total therapy one was the first to introduce the concept of tandem auto, and at that time with the VAD chemo, you can see that patients had already a PFS with a median time to 3.6 years, so that was not that bad at that time with the VAD and double transplant. And then we had almost 5 big trials to consider about single versus double auto. And you see there were the Italian, the Ovo, the French, 2 French studies, and then they all came to nearly the same conclusion. We got an efficacy on EFS with double transplant versus single, and for some trials we got also superiority on overall survival, but it was not that clear. So here there is a meta-analysis that took into account for several studies, including the Tunisian study. And here you can see that the meta-analysis is always favoring double transplant for EFS and overall survival. So there was an issue because the study design was not the same all within those trials, and there was some significant drop-off rate for patients that were randomly assigned to double ASCT, and they did not receive it. And sometimes patients will receive a second transplant at salvage. So that was quite difficult to analyze those studies. So when you regard into the French and the Italian trials, you can see that maybe that double transplant will benefit only for those patients who did not respond that well to the first one. And it was especially true in the French trial for the patients who are not achieving at least VGPR. And in the Italian study, it was the near CR. So after that, we had those total therapy 1, 2, and 3, and they all kept the double transplant, and you can see that there was always an improvement in PFS and OS with those approaches. Here is the same with the Ovo trial. So you remember we were considering VAD plus double transplant versus PAD plus double transplant, and some patients did not receive the double transplant because I think it was the Ovo that was doing the double transplant, and no, the opposite. Okay, thank you. So the German were doing the double transplant, and the Ovo was doing the single transplant. And you can see that the double transplant with PAD was way better than the single transplant with PAD. It was written 55% of PFS at 96 months versus 42. So there is that approach that is written there, that for patients who are eligible for transplant, if they got risk factors, they could receive a double transplant, especially those with the T414 translocation. So I will not go very far into that part because I think Professor Sandberg will talk about that later on this afternoon. But remember at last ASH, I think, or maybe 2 years ago, Michele Cavo presented that study. They were taking into account those 4 European studies, and some of them were having double transplants. And when you see for those, you can see there, sorry, for those high-risk patients that they should and could benefit from the second transplant with an improvement of the PFS of 21 months. And the same for the OS. You can see at 4 years, the OS is 76% versus 33%. So there is a consensus statement from the IMWG for those high-risk cytogenetics patients that double auto should be combined with bortezomib to improve the PFS in those high-risk patients. So these are the conclusions of Michele's talk. So there is a growing interest in the use of double auto incorporating bortezomib as part of induction, consolidation, and maintenance therapy for patients with high-risk features. And incorporation of next-generation proteasome inhibitors, IMiDs, and maybe a monoclonal antibody into the auto sequence can provide new treatment opportunities and improve the PFS and the overall survival for those patients in the next few years. Okay, so let's turn to the second transplant at salvage. At relapse. So Mohammed already gave a few lines on that. So we can skip that part. I think we had it twice already. So you know that we need to choose the treatment according the frailty and the age of the patient. For the auto, I think now we can go until 70 to the second auto, depending on the frailty and the comorbidities of the patient. And what is most important for sure is, do we have a graft? Because sometimes you know that we harbor stem cells for 2 or 3 auto, but sometimes we don't have enough stem cells left. So the question is, can we try to do another mobilization for those patients, and maybe plerixafor could be a useful tool, because when you already had 1 or 2 transplants, sometimes it's difficult to do the harvest. So unfortunately, you all know that slide, that your response is always longer within the time. So you can see from the regimen 1 to the regimen 6, the duration of your response is way less longer. So it could be the same for the auto. That's the issue, and that's why we need to take a cutoff to resume the auto. So what are the recommendations? So the last one was edited in 2009 by the IMWG, is based on clinical trial. That means you can retreat the patient if his PFS was at least as long as the median PFS of the clinical trial he was not issued but treated like. For example, for the VTD, auto VTD, the median PFS is around 36 to 40 months. So if you want to do the same sequence, you need to have at least that PFS. So here is an example of a patient. So I work in Toulouse, and for those that do not know that, there is a big Airbus industry in Toulouse. So that's why my patient is a 60-year-old aircraft engineer. So he presented in 2008 with anemia and bone pain, and he was diagnosed with IgG kappa multiple myeloma, and the M spike was 31 grams, ISS was 2, there was no fish abnormality. So he received at that time 4 cycles of VTD, achieved PR, then received his first auto in June, and the consolidation with 2 VTD. And then we quit treatment with a PR and an M spike at 7. At that time, the patient was not responding no more, so that's why we stopped at 2 VTD. So here is the evolution of the M spike. So you can see the relapse was proven around 24 months. And then as the patient was feeling great, we waited for his M spike to rise to 25, and then we have to give a treatment at that time. So we were nearly 36 months. So the question is, okay, this guy is still fit. We have a graft. Should we resume transplant or not? What would be your choice?
To do salvage before.
Yeah, always. But I mean, not auto directly, but there would be an induction. But would you transplant again that guy at that time? Okay. So what do we have? To monitor, to transplant, to do only Lendex plus a third drug, to put into a trial, or to retreat with Velcade. So that was that were the questions for us. So how can we answer to that question? So what about salvage auto? So Mohamed already told you that we had some studies concerning a salvage auto, and actually it was 19 studies of salvage auto that were published from 1996 to 2013, and within those studies the median PFS of the second auto was 12 months. With a median OS of 32 months. And you can see that the TRM was not that high, with only 4%, and the patients were responding to the second auto around 64%. So, can we propose a second auto with a median PFS of 12 months? It's not sure. So, what we can see is within the multivariate analysis of risk factors for overall and progression-free survival after the second auto, the important parameters are the disease status at the second auto and the PFS after the first one. So here you can see that the cutoff was 21.5 months. So that means less than 2 years. And sometimes we can say that more than 1 year is better. Not better, but we can propose the auto after 1 year, but you can see we need more than 1 year. We need nearly 2 years. And actually those studies got selection because they were an intent to treat. So, I mean, only patients that received that second auto were analyzed. And those patients had the chemosensitive disease, and they were salvaged with no new drugs. And we know that usually the second response is usually twice less. So that's an issue. We got that paper that was published in 2014 that tried to answer the question within a phase 3 randomized trial from the MRC. So you can see patients receive 4-pad induction, then they were randomized between melphalan 200 plus auto and cyclo weekly for 1 year. So that kind of strange comparator, but they chose that one. So, and what we can see is that the median time to progression with the auto was 19 months for those patients, and the 3-year OS was 80% versus 11 months for the patient receiving only chemo. 80% of patients responded with quite good response rates. And so that was the first prospective study to demonstrate the superior duration of response salvage of auto. Here you can see the curves. So on the blue is auto and the red is cyclo. So you can see there is a huge difference. And so PD occurred in 64 patients who receive auto versus 80% of patients who receive cyclo. And so I told you the median TTP was 19 months for the auto group. What was important is to compare the response considering the response after the first one. So you can see on the left side that patients who relapsed more than 24 months after the first auto had a better outcome than those who did not, because you can see the response was 13 months for the patients with less than 2 years of response after their first one versus 24 months. Here are the prognostic factors, so everything is favors to melphalan. And so the question is, okay, so we know that response may be twice less with second auto. So if we got a 24 months delay for relapse, can I offer a second one? That means that the second duration of response could be 1 year. And what about the combination regimen that we can offer to our patients? So I'm going to talk about Lendex and maybe the Endivo trial because they offered some new data. So we all know, sorry, this one is in French. So we all know that when you retreat with Velcade, it's around 6 to 9 months of PFS. Same with bortezomib plus anthracycline. When you treat with lenalidomide on first relapse, you can see it's a blue curve. The median of PFS is 17 months, and the median of OS is 42 months. When you give lenalidomide after lenalidomide, the median TTP is 17 months, and when you give thalidomide after lenalidomide or thalidomide, the response is only 6 to 9 months. So it's not good to give those thalidomide again, but maybe you can resume lenalidomide and you can have a 17 months TTP. So what about the carfilzomib? So you all know about that curve. So that was quite a huge PFS benefit with that CADI trial, because you can see that with the CADI, you reach 18 months of PFS. So that's better than the 12, 13 months we can offer maybe with that second auto. And the point is, should we use those treatment plus auto? So we don't have the response, because maybe you can do CADI or whatever. We can see there that you can do VTD, you got a good response after first relapse. Here with the panorama, you can improve response with panobinostat to Velcadex. Same for the CARD within the Aspire trial. So you can propose 26 months of PFS for your patients. So that means, should we incorporate auto into those first relapse trial and treatment? We don't have that answer. So maybe it could be something to do to try the new drugs with a second auto, because we don't have those trials. Usually we stop after the auto. And nowadays, you know that we all consider consolidation after the second transplant. So that may change the game. So here the same for the Elequant. Okay, and so you know all the ongoing studies with the new drugs at relapse. So what can we say? Salvage auto, why not? But maybe only if the duration of the first response is 36 months. Okay. But for chemosensitive patients, what about salvage combination therapy? Should we use triplet combination, and maybe CARD should offer the best response, the best response rates and the best survival to our patients? And I won't go into allo because that will be another talk this afternoon. And just to remember that ASCO slides is the cost benefit of those associations. So you can see, so the cost is red, the PFS is yellow, and the cost on PFS is the blue one. So it should favor maybe only RD. So back to our patient. So what did we do? And I will stop with that, and you can argue with me if you want. So we didn't choose a second auto for that patient. So we put him on Lendex, and then you can see he responded quite well for less than 1 year. So we had to think about what new treatment to give to him at that time. So what would you give him at that time? Should we reconsider the second auto at that time, or new drugs? So we choose not new drugs, we choose VCD. Because at that time it was 2012, so we didn't have that much new drugs. So we tried to resume Velcade and anthracycline, and alkylating agents. And so he had 8 cycles, and it didn't do very well with that VCD. So at that time it was 2013, and what do we have? Yes. So he received pomalidomide, and now you see he's no longer responding to pomalidomide. So I think he's going to have DARA at that time. But he won't have another transplant now. I think it's too late. Or maybe sometimes we do that transplant when those patients got the bone marrow failure, and we put some melphalan low dose, around 70 milligram per square meter, and to put the stem cells to giving a second chance to receive new drugs. Thank you.